Welcome to Twin Take Tuesday.
Okay, our debate today. Do you require a colectomy when a patient presents with perforated diverticulitis that is controlled with a percutaneous drain?
Absolutely, you need to really recommend a colectomy after this patient has an abscess with a percutaneous drain. ASCRS says that of the 65 patients with perc drains, up to 75% of the patients had recurrent episodes. So this is highly morbid, and absolutely they should have very long discussions about getting their colon taken. An interval elective colectomy prevents catastrophe with a patient having recurrence, needing an emergent heart rinse procedure, and having smouldering complications like stricture and further chronic pain.
I don't know if that's entirely always the case. I think that more modern literature might show that some of these patients can be managed without having to have a colectomy long-term, that the risk of long-term perforation is really minimal. Only about 20 to 30% of these patients have ongoing surgical catastrophes that would require a colostomy bag. So I really think that it doesn't necessarily warrant a colectomy and certainly requires a conversation with the patient and the provider.
That's true, but elective surgery relieves the patient's anxiety of having another recurrence and can improve long-term survival and chronic pain.
Elective surgery, though, isn't totally benign. So why would we operate on somebody electively, even if there are risks of things like surgical site infection, possible need for a colostomy, and also like baseline comorbid conditions that can make general anesthesia and in hospital stay more complicated?
The verdict, I think, just like all things surgery, it's patient specific. It comes down to the patient, their surgical history, their chronic medical comorbid conditions, their antithrombotic regimens, and if they would tolerate surgery.
Little by little, case by case, you have to make decisions together.